Good afternoon, student. Today is the another nerve. This is the hypoglossal nerve you have to study. So come to these slides of the hypoglossal nerve. You all know the hypoglossal nerve. It is the 12th cranial nerve, and it supplies all muscle of the tongue except the palatoglossus. And the hypoglossal nerve is spinal in behavior but cranial in outlook. It means it lies in a series with the third, fourth and sixth cranial nerves and the ventral root of the spinal nerve. It represents the fusion of the ventral root of the 3 or 4 pre-cervical nerve and the dorsal root of which disappear entirely with eventual loss of the sensory component. Therefore, the hypoglossal nerve is spinal in behavior but cranial in outlook. So, again, this slide, you have to identify the position of the nerve. Again, in the midline, this is the abduction nerve, then facial, then glossopharyngeal, and then this is the hypoglossal nerve. Okay, this is the hypoglossal nerve. The component of this hypoglossal nerve. The hypoglossal nerve, it has only the somatic motor component. It has only the somatomotor fiber, and it supplies the extrinsic and the intrinsic muscles of the tongue except the palatoglossus. The pre-cervical component, the ventral root of the pre-cervical nerve, fourth pre-cervical nerve, which unite, which fuse to form the hypoglossal nerve, and the dorsal root, it disappeared. And the myotome of these segments are called the occipital myotome. So the hypoglossal nerve is the nerve of the occipital myotome which migrate to form the muscle of the tongue. Come to this origin. From hypoglossal nucleus, which is situated in the medulla in the lower part of the floor of the fourth ventricle. The hypoglossal nucleus, it is 2 cm long and lies ventromedial to dorsal nucleus of the vagus. So these are the hypoglossal nucleus. Okay, this hypoglossal nucleus situated in the medulla in the lower part of the floor of the fourth ventricle. This is the fourth ventricle and this is the hypoglossal nucleus. Okay, it is about 2 cm long and it lies ventromedial to the dorsal nucleus of the vagus. The nucleus is connected with the precentral gyrus of the opposite side via the corticonuclear tract. So this is the hypoglossal nucleus, this schematic diagram. Hypoglossal nucleus, the nerve coming out in between this pyramid and the olive. This is the hypoglossal nerve, and it has the somatomotor fiber which supply the muscles of the tongue. Again, these are the 4 ventral root of the precervical nerves. It unite to form the hypoglossal nerve. It goes to the hypoglossal canal and then it supply the muscles of the tongue. Then come to the course of this hypoglossal nerve. This intraneural course, fibers run forward through the medulla, bounded laterally by the reticular formation inferior olivary nucleus. This part, this is the olivary nucleus. Okay, so laterally there is inferior olivary nucleus, and medially medial longitudinal bundle, the tectovulvar tract and pyramid. So medially these are the bundle, medial lemniscus and the pyramid, medial lemniscus and the pyramid, and this is the inferior olivary nucleus laterally. Then come to this superficial attachment by several rootlets in the groove between the olive and pyramid of the medulla. It is the superficial attachment. You may detect this hypoglossal nerve by the several rootlet, and the rootlet is situated in the groove between the olive and the pyramid of the medulla. Then come to the intracranial course. The root of the nerve ran laterally behind the fourth part of the vertebral artery and are united into two bundles which perforate the dura mater separately. So these are the two bundles. It is the upper one, this is the lower one. These two bundle, it perforate the dura mater separately and then unite. Okay. Again. Then come to the exit from the cranium. The two bundles of the nerve come out of the anterior condylar canal and unite to form one. This canal may be divided into two. Through this canal also passes the meningeal branch of the ascending pharyngeal artery and the recurrent meningeal branch of the hypoglossal nerve and one emissary vein through this anterior condylar canal. Then come to the extracranial course. Up to the posterior border of the hypoglossal muscle. The point A, this is up to the posterior border of the hypoglossal muscle, how the nerve goes up to this hypoglossal muscle. The nerve lies on a deeper plane than the internal jugular vein, internal carotid artery and the 9, 10th and 11th nerve. It passes laterally and downward behind the internal carotid artery, 9th and 10th nerves to reach the interval between the internal carotid artery and the internal jugular vein. Then it descends vertically between vein and artery, deep to posterior belly of the digastric muscle, stylohyoid, posterior auricular and the occipital artery. Below the digastric, the nerve hooks around the lower border of the sternomastoid branch of the occipital artery and crosses superficial to the internal and the external carotid artery. And on the hypoglossal muscle, it runs upward and forward on the hypoglossus deep to the tendon of the digastric, stylohyoid and the posterior border of the mylohyoid. Here the relations are from above downwards like this. So this is the 12th cranial nerve. And look at this diagram. So this is the hypoglossal muscle. It runs upward and goes towards the tongue in this region and supply the muscle in this region. And from above downward, the relation are the lingual nerve. These are the lingual nerve and this is the submandibular ganglion. And deep part of the submandibular gland with the duct. And these are the deep part of the submandibular gland and the duct. And the hypoglossal nerve with the vena comittentis. Along with this, there are two vena comittentis along with this nerve. And then suprahyoid artery. These are the lingual artery. One branch of this is the suprahyoid artery. It goes along this. And the greater corona of the hyoid bone. These are the relation of this hypoglossal nerve on this hypoglossal muscle. From the anterior border of the hypoglossus up to the tongue, it ascends on lateral surface of the genioglossus and enters into the substance of the tongue as far as tips. So in a real dissection, this is the hypoglossal nerve, this is the hypoglossus muscle. It goes to the genioglossus and it ascends on this lateral surface of the genioglossus and then enter into the substance of the tongue as far as its tip. And this is the hyoid bone. Then come to the distribution of this hypoglossal nerve. Muscular branches. It has several muscular branches. The muscular branches to the styloglossus, genioglossus, hyoglossus, chondroglossus and the intrinsic muscles of the tongues. The distribution of the C1 nerve via hypoglossal nerve. You all know this part. It forms the ansa cervicalis. So C1 nerve distribution via this hypoglossal nerve. Come to this. No slide for this. Sorry. Answer cervical is 1 minute, please. So distribution of severe nerve via the hypoglossal nerve. One is the meningeal branch. Then the descending hypoglossal supply superior belly of the omohyoid and join with the descending cervicalis to form the ansa cervicalis to supply the sternothyroid, inferior belly of the omohyoid to thyrohyoid and to the geniohyoid. Come to this slide. From this region, one branch goes to the recurrent meningeal branch. Then the C1 and C2, here C1, it along with this hypoglossal nerve, it forms this ansa cervicalis. The ansa cervicalis, it is formed by this descending part of this hypoglossal nerve and the descending cervicalis nerve. The cervicalis part, it is come from the C2, cervical 2, and the descending hypoglossal part, it is formed by the C1. Okay. And from the C1 and C2, it supply all the muscles in this region. This is the thyrohyoid muscle, superior belly of the omohyoid, and the superior belly and inferior belly of the omohyoid also supplied by this sternothyroid, sternohyoid, and all this muscle is supplied by this ansa cervicalis. And this part, this ansa cervicalis, it is very much important to remember during examination. Then come to the applied anatomical part. Supranuclear lesion usually produce a transient mild weakness of the contralateral side of the tongue. There is considerable individual variation. However, on an occasion, a supranuclear lesion can produce what appears to be nuclear lesion due to degree of the weakness. The transient nature is usually the clue. And nuclear lesion produce atrophy, weakness or paralysis and fasciculation. Amyotrophic lateral sclerosis and polio are the two causes. Syringobulbar, infarction and intraspinal tumors are other etiologies. Nuclear lesions are often bilateral because of the closeness of the two nuclei in the medulla. And the hypoglossal nerve involvement after the individual fiber exit from the medulla is seen with the many of the lesions that affect the spinal accessory nerve. Tumors can compress the nerve in the hypoglossal canal and in the jugular foramen. Basilar meningitis due to granulomatous infection or carcinoma can produce hypoglossal lesion. Unilateral 12-nerve palsy has been reported as one of the most common cranial mononeuropathy due to metastasis of the cancer. And the unilateral injury, in case of unilateral injury of this hypoglossal nerve, the tip of the tongue tilts towards the paralyzed side and atrophy larynx deviated to the side, atrophy larynx deviate to the sound side. Okay. In case of unilateral injury, the tip of the tongue, it deviate towards the paralyzed side and there is atrophy of this part of this tongue and the larynx deviate to the sound side and it looks like this. It looks like this is the atrophy part of this tongue and the tip deviate towards the affected side. Innervation, muscles of the tongue except the paratoglossus function movement of the tongue. A unilateral lesion can cause paresis, atrophy, furrowing, fibrillation and fasciculation on the affected half. On protrusion, tongue deviate towards the affected side due to unopposed action of the contralateral genioglossus. Okay. So, if there is a paralysis of the one part of this tongue and the deviation of the tip, there may be a hypoglossal nerve injury. Thank you. This is all for this hypoglossal nerve.